This program is brought to you by Emory University.
Good morning, everyone. We're going to go ahead and get started. Welcome to Cardiovascular Grand Rounds. This morning we have Dr. Neal Dickert with us. Most of you know Neal. Neal's an assistant professor here in the Division of Cardiology and did his cardiology training here, but previously came to us from Hopkins. Neal has, as you all know, a background in ethics and ethics in a little different way than most of us might think of it, and has been a very successful faculty member here in the division. He received one of the very prestigious Greenwald grants and is funded by PCORI funding as well as other sources. And I always find Neal keeps me thinking. So we're going to talk about decision making in cardiology. Are there decisions to make in cardiology? I don't know. Maybe. Neal.
Thanks. This is a talk that is, I hope will be interesting for you guys, and really is an area that I've sort of worked around for a while, and one in which I'm becoming a bit more interested in. But this talk in some ways has grown out of a lot of the conversations that many of you all and I have had about care of our CCU patients and others, and I hope will be something sort of fun and different. So this, as we all know, we have lots of interesting kinds of decisions that we have to make in the context of cardiology, and some of the difficult ones are really some of the common ones that we face. So incredibly common issues of chronic care of cardiology patients, like anticoagulation for atrial fibrillation, use of lipid-lowering therapy, things that we think about a lot and engage with our patients a lot. Higher stakes decisions about invasive procedures like mechanical circulatory support, aggressive structural interventions, and interesting and challenging end-of-life decisions, whether that's related to sort of issues of code status, hospice decisions. I'm preaching to the choir to say that we face a lot of interesting and challenging decisions. And there's a lot of different reasons why they're challenging, right? So some of it's an evidentiary issue. We have studies that we have things that we treat where we really don't have data and we have to go based on our best experience. We have things that we, as a field committed to gathering of data, have assembled a large volume of conflicting data. I recall last year, I think there were 3 issues of JACC in a row saying something different about the risk of stroke with a CHADS-2 VAS score of 1, followed by, I think, a paper that said it doesn't even matter if you have atrial fibrillation, the stroke risk is the same with CHADS-2 VAS. So we have lots of ways in which data conflict and often aren't there to guide our decisions. We have practical constraints that we all know well, whether that's financial constraints, legal or regulatory constraints, and patients are complicated, whether they have communication barriers or idiosyncratic preferences. Those decisions can be difficult. These are not the kinds of difficulties that I want to talk about, though. So I want to talk about things that get a bit more at the physician-patient relationship and about the ways that we use or don't use information. So as we all know, there's been significant evolution and constant discussions about the ways that providers and patients should relate to each other, from very paternalistic notions as illustrated by the script on the left that just says, do what I tell you, to very different kinds of paradigms where patients are not only the sort of focus of the clinical encounter, but the complete drivers of the clinical encounter. And in recent years, there's been a proliferation of this notion of shared decision-making, which is not a foreign notion. It's something that makes a lot of sense. I think Larry, for this figure, this was from a recent review article that he published. But essentially, the idea with shared decision-making is one that's hard to dispute, right? We should bring a combination of available evidence, our clinical judgment, and patients' values and preferences together to try to arrive at treatment courses that make the most sense with all of those things. This is just a relatively straightforward definition. It's actually from an advocacy group, but reflects a lot of other definitions of shared decision-making that have been put forward, which says that this is a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account the best scientific evidence available as well as the patient's values and preferences. that's a sort of model of arriving at a treatment decision that in many ways is hard to argue with, in part because it incorporates both a notion of respect for patients as autonomous as well as an appreciation for the areas in which both physicians and other providers and patients are really experts. This is not just something that people have advocated, it's something that's been advocated at a high level and sort of put into action to the extent that things like the Affordable Care Act have set aside money for creation of decision aids and other ways to kind of promote shared decision making. It's certainly been a priority in several IOM reports. And we're seeing it in the guidelines from professional societies. Look at recent lipid lowering in particular has been really emphasizing the concept of shared decision making. Especially in what we call preference-sensitive decisions, right? Those are a set of decisions in which we face many of them, where there are several reasonable medical alternatives and where patients' values and preferences should have an important impact on the choice. So the flip side of this, it's a pretty good idea, and we all know it's really hard to carry out. I mentioned evidentiary challenges, practical challenges related to money, regulatory issues. All of those are clearly present, but that's not what I want to talk about today. What I want to talk about today, in some ways, are more fundamental challenges related to how we process evidence, how we and our patients use different kinds of data, ways that we communicate and frame things that can cause problems of which we're often not aware, and sometimes we are aware, and how the structure of decision-making processes can have important impacts on what we do and what we decide. So my objectives in this talk are first to articulate some specific limitations and challenges that we face in carrying out shared decision-making, particularly to give some data from the cognitive psychology, behavioral economics kind of literature about key biases we have and how that relates to decisions that we make, and talk about areas of breakdown that we commonly run across. I want to talk about the role of some different kinds of influences and think a little bit with you guys about implications for how we work with patients and possible strategies for moving forward. So what I'll start with is sort of elaborating some commonly known sources of bias that we have in a way that I hope is sort of fun and different from some things that you may have heard before. So the first few examples I'll mention are ones that are pretty well known in the field of social science in particular, and really sort of grounded in some groundbreaking work by Kahneman and Tversky, or Nobel Prize-winning economists who really sort of founded the field of behavioral economics that has taken a lot of has really risen to prominence recently. And they in a key paper called Judgment Under Uncertainty in the 70s from Science articulate three kinds of heuristics that we use, and many of us are familiar with, to try to understand or to try to work through situations where we have to reason probabilistically. And those three heuristics that can lead us into real trouble sometimes are the representativeness heuristic, the availability heuristic, and the anchoring and adjustment heuristic. So the representative heuristic is pretty straightforward, right? This is where we evaluate probabilities based on the degree to which object A is representative or looks like an instance of class B, right? So this is, if it looks like a duck and quacks like a duck, it's probably a duck. Well, so they did some experiments that show ways in which that kind of reasoning really can get us into trouble. So just to give one example, they describe a guy, Steve. So Steve is shy and withdrawn, invariably helpful, but with little interest in people or in the world of reality. A meek and tidy soul, he has a need for order and structure and a passion for detail. So they point out the representativeness heuristic may lead one to believe that Steve is more likely, for example, to be a librarian than a farmer. But the issue is that really fails to consider prior probabilities, right? There are a lot more farmers than there are librarians in the world. To give a sort of reverse example of the way in which the representativeness heuristic can screw us up in other spaces. So this was an experiment that they did where they gave people this description. Dick is a 30-year-old man. He's married with no children, a man of high ability and high motivation. He promises to be quite successful in his field. He is well liked by his colleagues. And they ask people, what's the probability that Dick is a lawyer or an engineer? Right? If you know nothing about where Dick came from, that should be essentially 50%, because this describes absolutely nothing about either of those dispositions. So then what they did is they altered the sample from which Dick was chosen to be a representative, right? So they gave people situations in which they described a world in which 70% of people were engineers and 70% of people were lawyers. The fascinating thing is, in both cases, subjects tended to say that the chance that Dick was an engineer or a lawyer was 50%. Right? That doesn't work, right? If there are 30% engineers, his chance that he's a lawyer is 70%. If there's 70% engineers, his chance is 70%. They completely ignore in these kinds of frames prior probabilities that are important to moving forward. And in clinical medicine, this is something that's not uncommon to us, right? The failure to consider pretest probabilities is an easy mistake that both we and our patients can make. It's something that we're sort of constantly thinking about in the context of evaluating things like chest pain in low-risk populations. And in some ways, it's tough for us as specialists, because often we see only the people who get referred. We may not necessarily see the people who represent the broader population that has a particular type of symptom. So there's important reasons. Don't get me wrong, I'm not saying it's not important for us to consider low probability diagnoses, but it's really important for us to recognize the pretest probabilities so that we can properly think about our clinical decisions. So the availability heuristic is a little bit different, and it's the notion that we assess probabilities of an event by the ease with which instances or occurrences can be brought to mind. So essentially, it's how sort of strongly something resonates with you. This, I think, is another great illustration of ways in which we are cognitively fragile beings. So the group of subjects were given different lists of names of men and women, right? They were systematically varied based on whether the list contained numerically more famous men or women. So the numbers of men and women were always the same. They varied whether or not there were more famous of one or the other. And subjects systematically guessed the list contains more of whichever sex had numerically more famous people. So this, I also think, is a common kind of heuristic that can get us into trouble, right? For all of us, the zebras stand out, right? There's no question about that. So does the one that went wrong. For our patients, you know, they come in with a set of symptoms and they say, well, my neighbor felt like that when they had the heart attack. Or the last time I had a procedure, it was terrible. Right? These are reasonable kinds of, or not, reasonable is not the right word, these are common kinds of reasoning, but we all know that they can lead us into real trouble. One of the areas I think this is really interesting and tough is in the space of screening for athletes, and Jonathan and I have talked about this a lot. Obviously, there's huge, very difficult challenges about exactly determining what the level of risk is, but there's no question that high-profile incidents with prominent athletes, for example, can really sort of drive people's reasoning in this sort of circumstance. And the availability heuristic can really quickly drive bad decisions on the part of both providers and patients. So the last one, I think, is just, in many ways, also very common, but really humbling, and this is the anchoring and adjustment heuristic. So Kahneman and Tversky took a random group of subjects and essentially put them in front of a wheel. They spun the wheel. Wheel had numbers from 0 to 100. Didn't matter where it hit. And then they asked them to estimate the percentage of African countries in the United Nations, right? So no connection to the wheel, right? Yet the estimates that people gave systematically varied based on the number that they saw, right? So the mean guess of the number of African countries in the UN was 25 when people happened to see a 10, and it was 45 when people saw a 65. Right, so this does not make me, I guessing it doesn't make you either optimistic about our ability to reason through problems. But it's really sort of impressive in ways that things that shouldn't frame our decisions or assessments seem to do. And there's lots of ways in which I think this can operate really subtly in clinical medicine. We don't usually have wheels that we spin in front of our patients, but there are a lot of other ways in which numeric concepts can frame decisions that we made. And it's an important part of this framing effect, which is well described, where systematically different decisions are made based on the valence of information that's provided. So this, I think, is another great, again, a lot of these data are old, which is interesting. But this is a great study published in the New England Journal now many, many years ago, where they took a group of patients, graduate students, and physicians and gave them different descriptions about radiation and surgical treatment for lung cancer. Right, so people were randomly assigned to receive presentations of these data that varied based on 3 characteristics. So one was whether the numbers were given in terms of the likelihood of survival as opposed to the likelihood of death. The second is sort of a cumulative probability of one of those events as opposed to framing it in terms of life expectancy. And the last is whether the treatments themselves were named. Now, I'm only going to focus on the first because it was the most dramatic findings. But this is important to know these were hypothetical decisions, but people got detailed descriptions. They got tabular data. It wasn't as if someone just read a few sentences and asked them to make a gut level decision. Right, so I'll give you the 2 descriptions that they got in terms of framing it in terms of dying or framing it in terms of chances of living. So the dying frame was, of 100 people having surgery, 10 will die during treatment, 32 will have died by 1 year, and 66 will have died by 5 years. Of 100 people having radiation therapy, none will die, during treatment, 23 will die by 1 year, and 78 will die by 5 years. The living frame, of 100 people having surgery, 90 will survive treatment, 68 will be alive at 1 year, and 34 will be alive at 5 years. Of 100 people having radiation therapy, all will survive treatment, 77 will be alive at 1 year, and 22 will be alive at 5 years. And this, I think, is staggering. So this shows the number of people who chose radiation therapy in each of these groups. Now, this is just within the sort of cumulative probability group, so the numbers on the very top and the bottom, I'll explain why those are a little bit different. But it's really pretty impressive that across the board, all 3 populations systematically elected to choose radiation therapy when it was framed in terms of their chances of dying, and were much less likely to choose radiation therapy when it was framed in terms of their chances of living. Overall, and I think the most striking group is that the physicians were, in fact, more affected than any other group. Right, so overall, there was 42% versus 25%. That was among all the different sort of ways that they randomly assigned, but based on, in all the different sort of formulations, there were 42 versus 25% choosing radiation based on whether things were framed in terms of survival or framed in terms of death. So there's lots of ways in which we have to frame this kind of information all the time for our patients. I think it's important to be aware of ways in which that may make a significant difference in the decisions that they made. These are just examples of kind of preference-sensitive decisions that our patients face all the time. CABG versus PCI for complex multivessel disease, revascularization versus medical therapy for stable CAD, anticoagulation for AFib, again, and surgical versus percutaneous valves. So one of the biggest challenges is this doesn't give an obvious answer about what the right frame is, right? Some of these issues, we can find ways simply to correct for things like the representativeness, errors of representativeness heuristics. But how we frame issues doesn't really have a clear neutral. Just to give some more examples of ways that framing can be interesting, they've done, in a later series of experiment, also Kahneman and Tversky did some work looking at whether or not people frame things differently or think differently based on whether things are gains or losses, right? So if you ask people to choose between, these are all monetary trade-offs, but you ask people to choose between a sure gain of $240 or a 25% chance to gain 1,000 and 75% chance to gain nothing, most people take the sure gain of $240. What's interesting then is if you ask them to choose between a sure loss of $750 and a 75% chance to lose 1,000 with a 25% chance to lose nothing, most people choose the 75% chance to lose 1,000 and 25% chance to lose nothing. So this is another example. There's many other studies like this, but with this interesting tendency that we have to be risk-taking in the face of potential losses and risk-averse in the face of potential gains. I think we see that a lot in terms of people's mindsets in situations of desperation, and then in contrast in situations where we're looking at relatively low risks of bad outcomes. So I think this is can lead to these sort of interesting biases of omission and commission that I think we see a lot. So a commission bias or preference for action, I think we all see that in patients' desire, for example, to fix coronary disease and difficulty accepting medical therapy in situations where they feel like their risk of a bad outcome is very high. And people tend to be much more aggressive and risk-taking in that setting. In contrast, I think situations like stroke risk with atrial fibrillation, where often people may perceive these risks as relatively low, their concern with a risk of a bad outcome like a bleed might be very high. So we do see these kinds of loss-gain issues, I think, manifest themselves in omission and commission biases a lot. So another kind of bias that's really interesting, and I think we certainly see this and deal with this a lot in the CCU, is issues related to optimism bias, right? So this is a very small study, but I think it's a good example of a very common phenomenon that's been observed across many medical fields. There's a recent sort of small interview study with patients who had VADs implanted. 9 out of 15 thought they were implanted as a bridge to transplant. Or excuse me, 9 out of 15 thought that they would eventually get a transplant. But 7 of those 9 had been implanted as a destination therapy indication. And they had pretty good reason to believe that that was not an issue of never having been told that. And this is certainly something that's been demonstrated in many contexts. And there's lots of ways in which that appears to be an important misinterpretation or misunderstanding of really key data, because a lot of these issues about prognosis should have an important impact on the decision that you make. We see this often in end-of-life situations. It's been perhaps best studied in the context of kind of innovative therapy and early phase clinical trials. This is a nice study from a few years back where they interviewed people who were currently serving as surrogates for a family member in an ICU. So they were hypothetical scenarios with people who were actually the surrogates of patients currently admitted in an ICU. And what you can see, this just shows the answers people gave when they were presented with each of the prognostic statements on the left. It's a little bit hard to read, and I'll read a couple of them. But essentially, they would give them a particular statement, and then you'd have a line with, marked out spots from 0 to 100%. They'd have to say the likelihood of survival under each of those statements. So as you go up towards the top, those are very positive statements, like he will definitely survive. You move down, and they get in the middle is, I'm concerned he will not survive. It's possible he will not survive. All the way down to, it is very likely he will die. It is unlikely he will survive. That means he will likely die. He has a 5% chance surviving, and he will definitely not survive. And what's fascinating is there's a shift, a systematic sort of skew towards more optimistic statements as the statements got more negative, right? So if you say he has a 5% chance of surviving, the median response was about a 15% chance of survival. The mean was about a 23% chance of survival, right? That's pretty concerning when you think about people getting the wrong message. So we've all had these patients And they pose really interesting challenges. So Lloyd's not the sharpest tool in the shed, and this probably doesn't explain what's going on with him, but there's been some interesting work done looking at, why do people have these sorts of reactions? This, I think, is really illustrative. So this is from a colleague at Duke and some others who did work in the context of early phase cancer trials. There's been this very commonly observed phenomenon where people say, I've got a very high chance of benefiting from studies where we know that often these are phase 1 studies or dose finding studies, toxicity studies, pharmacokinetic studies. They're not even designed they're not designed around the prospect for benefit. So he started asking, where does this come from? If you focus just on the ones on the left, because those are more straightforward, the one that is there indicate phase 1. You see very different answers to a question about what is the likelihood that you will benefit from participating in the trial. That's the belief column, where you essentially get, over 50% thinking they're going to benefit. Whereas if you go to the frequency one, which is what is the likelihood that a patient enrolled in this trial will have benefit, you get substantially lower estimates, right? So in the 30-40% range. And this is really, I think, an important clue that many times what patients may be telling us in the face of this sort of optimism bias isn't that they don't understand what they're saying. It's that they're saying something and not just giving us an answer, right? So there's a series of papers that have looked at this. Both of these two studies that I've reported have done qualitative interviews with patients about kind of where this is coming from, and I think we've all seen this. So one is that optimistic statements that people make can be important performatives. And a performative is essentially the idea that this statement itself has some impact on the likelihood of that outcome happening. So when people say that they have a poor chance of doing well, they think in some meaningful way that might mean that they're going to not do well. Second, people can have faith or hope-based reasons for having positive beliefs about themselves. Right? They may believe that, whether for spiritual reasons or other kinds of reasons, they're just going to do better. And it doesn't mean that they don't understand the probabilistic information that you've given them. Third, people can conceive of diseases as a battle. They define themselves by fighting it and being optimistic and sort of maintaining a positive attitude in the context of a battle is part of how people conceive of playing that role. Fourth, people feel like the data just don't apply to me or to their loved one, right? This is the sort of he's a fighter kind of phenomenon. I remember very distinctly a patient that we had in the CCU, it was a couple of years ago. It was a patient had a very long battle with complications related to congenital heart disease who had a prolonged arrest, and we had conversations with her family where they say, look, people have told us she's not coming back probably 20 times over the course of her life. We have no idea how to interpret what you're telling us. We're with you. They were entirely reasonable in every way, but they had a very difficult time figuring out how do these prognostic data apply to that patient. And finally, people just say they don't think we know what we're talking about. Right? And there's a lot of times where, with regard to prognostic information, they might be right. There's times where they're not. But it's important to recognize that a lot of these optimistic statements don't necessarily reflect a sort of factual misunderstanding. There are important issues that may be going on that patients have that we need to be aware of. We had a good example of this the last time I was on service. We had this patient who was in the CCU on dual inotropes requiring high-dose diuretic, had persistently high filling pressures, and wasn't a candidate for VAD or transplant. And there had been a decision, the patient had decided she wanted to go home with hospice. And when we started talking with her a little bit about kind of getting the details worked out, there were some, I forget exactly how we stated this, but she just sort of looked at me and said, no, I'm not going home to die, I'm going home to live. And all of a sudden you hear the brakes getting slammed on, and not really clear about what she meant by that, and raised a lot of concerns on our team's part about whether she really wanted to have the plan executed that we had kind of put together for her and with her. And what became really clear was that in this patient's case, that was a very important statement for her about not saying that she was giving up on God's potential for healing her. And it was an important statement about saying she wasn't taking a sort of giving up role. So we had these very interesting conversations where I was really concerned she, particularly given her state of cardiogenic shock, it wasn't exactly clear what she understood and what she didn't. So we had these we kind of constructed this analogy of kind of going off a ramp or a cliff, and we didn't really have any way to give her a parachute or get her back up, and we knew that eventually when you do that, you're going to hit the ground, and we thought she was going to hit the ground pretty fast. She then, in the context of every subsequent discussion, reiterated that analogy to us, made it very clear that she understood exactly what was happening, and that sort of gave us a way to talk about it without using words that she felt like she couldn't say. So I think that the sort of take home from the optimism piece is that, number one, it's very clear that it doesn't always indicate confusion, but it can really screw up our attempts to try to engage in a shared decision-making process with patients. And I think our challenge is really to recognize when misunderstanding really does exist and how to kind of ask the right questions so that people are answering the question we think we're asking and not giving us the answer that they want to be the case. So another way in which I want to sort of highlight ways in which our decisions are sort of fragile is to talk a little bit about decision structures, right? So there's been a lot of work recently looking at different kinds of default options. Right? Default options are sort of a passive choice. What happens when you don't actively choose something different? And default options can vary and can be varied by people setting up decisions. And we know that the choice of defaults can exert really powerful influences on decisions, right? That's in the space outside of healthcare. That's why this phenomenon of kind of automatic contributions to 401k programs and other kinds of things are set up so that people will do things that are thought to be good for them, but where they don't necessarily take the initiative to do it on their own. Within healthcare, we see there's good examples of the effect of generic prescription defaults, order entry systems that may prioritize particular medicines because they're thought to be ideal choices in certain circumstances. And these are really forms of what are called nudges, right? And nudges in the context of decision structure are important because, and defaults are a good example of this, because number one, they don't actually change what options do exist for people. They don't say you can't do A or B. They simply are going to sort of shunt you or push you towards A or B. They don't overtly change the terms or consequences of decisions. It's not like you're saying there's a punishment, for example, for not enrolling in your 401k, or there's a punishment for making certain kinds of decisions. So they don't change the terms of the decision. In that way, they're not really sort of liberty-restricting kind of ways of influencing choices. And that's why the sort of advocates of nudges have been termed libertarian paternalists, which is a wonderful terminology, I think. And I want to give you some data from one recent study that I find incredibly thought-provoking and really humbling. So this was a study that a colleague of mine at Penn did, where he took patients who had a terminal pulmonary diagnosis. It could be several different ones. The key was it was a legitimately terminal pulmonary diagnosis without transplant options or other kinds of things. And they were defaulted to one of three advanced directive forms. They were told that they were going to get a different kind of a form, so they were warned ahead of time that they would be part of this study. And the three advanced directive forms varied based on nothing other than what was pre-checked, right? So the first one had a box where they pre-checked sort of comfort measures. The second one had one where they pre-checked aggressive care measures. And the third had nothing pre-checked at all. The patients were responsible for checking the one that they wanted. In all cases, they were instructed that the boxes were not intended to say what they should do. They should choose whatever they wanted. This was just a sort of pre-populated with these answers. And they were offered the opportunity afterwards, importantly, to kind of go through their choices and think through whether that really did reflect what they wanted to do. So this, I think, is really striking, right? So this shows the number of patients who chose a comfort-oriented goal of care, right? So the blue on the top is people who were defaulted into comfort care, so they had the pre-checked box for comfort care. The red is people who had nothing pre-checked, and the green is people who had the kind of aggressive care pre-checked. And those differences are pretty striking, right? 77 versus 60 versus 45% choosing a comfort care advanced directive. This persisted with regard, the form also contains sort of choices about specific therapies, and you see the exact same trend across therapies like feeding tube, dialysis, mechanical ventilation. What I think was perhaps most fascinating is that when they went back and sort of talked to people about this, not one person changed their choice. Right? There were two people who wanted to kind of have a conversation, and not one out of these folks made a different decision about what they wanted their goals of care to be. And these were people who were randomly selected. Right? So this is pretty humbling, I think, that this sort of trivial change in a form had such a major impact, and it's one that people endorsed. So I think together these findings suggest that the default structures have a very important, large effect. It does show that they're probably not overpowering, right? You had a substantial number of people in every group who chose the alternative course. And it probably suggests that people don't have the kind of strong, well-formulated, well-articulated preferences about what they want, which in some ways is not surprising because most people don't face these decisions that regularly, right? These are the kind of things that people might have thought about, but most people haven't faced big medical decisions that they're having to face many, many times before. Just in case you're wondering, so one explanation of this might be, well, they didn't change their thought because they kind of didn't want to, from a sort of cognitive dissonance reason, they didn't want to kind of go back and kind of change their mind. There's another study that was recently published. I think it was entitled, "Warning, You're About to Be Nudged," right? It gave people sort of full-on notification they were in fact going to be defaulted into a particular option, also in the advanced directive space. Made no difference. These effects are present whether people are aware of them sort of pre and post. So I think these studies are really important. In particular, they call attention to the valence of information that we present. And I think it really is humbling to us as providers to recognize the importance, in many ways this is a manifestation of a framing effect, but to recognize the importance of how we construct the passive choice for people, right? When you have patients who are at the end of life, do you say that, do you essentially have a communication that's an unpre-checked box, or do you sort of pre-check one of the boxes for the patients to help them work through the decision? And I think this is a really, really interesting and obviously controversial topic. So should we throw in the towel? No. I want to talk now about what I think are a handful of simple steps that I think we can do to kind of deal with these limitations, and then sort of engage you guys in some discussion of of some of the more controversial issues. So simple steps are ones that are probably are pretty commonsensical, right? So countering things like the availability heuristic with other examples, right? So when the person comes in saying their neighbor just had a heart attack, you say, well, your neighbor just had a heart attack, but I see patients all the time who have symptoms just like this, and they have nothing wrong with them, right? So importantly, kind of people have this sort of latch on to specific cases, but it's important to give them examples of why that case is not necessarily indicative of the whole class. That's a pretty commonsensical thing, and I also don't mean to imply that it's always easy, but that's I think pretty straightforward. Another issue is sort of for us and for our patients, again, really sort of conscious emphasis on pretest probability. And these are really important issues in situations where there are real downsides to choosing certain interventions or strategies. Letting people know that, look, of a number of people that fit the exact same picture as you do, there's a very low likelihood of you're having the problem that you're worried about. That's an important issue. A second sort of step that's important, and it can have a big difference, an impact on how patients make decisions and how we make decisions with them, or how we choose to represent things numerically, right? So there's a lot of work that's looked at, and this is a good example from the Mayo Statin Choice Decision Aid. The use of, for example, absolute numbers, pictorial representations like this, that can help people to understand probabilistic information better than other ways, right? So this shows the green is obviously people who will have no heart attack. 12 is people who will have a heart attack out of 100. And this is I forget exactly what I input into the system, but this was I think a 70-year-old hypertensive patient. I forget whether there's any other, what else I put into the model. That's not important here. But on the left is their current risk, and on the right is with standard dose statins, for example. And this is a nice sort of pictorial representation in ways that's been shown to be easier for patients to comprehend. And tries to, I would say, frame this in a relatively neutral way, right? So we talked about this sort of living versus dying orientation, and in this decision aid, there's very explicitly choices of, both provision of the number of people who will likely have a heart attack and the number of people who won't have a heart attack. So it's trying to provide sort of a balanced picture. That said, if you look at the number on the right, it starts with the number of people who have had a heart attack, the number of people who won't, and then the number of people who will be saved by taking this medicine. I'm not accusing them of trying to sort of shun people one way or the other, but you can imagine, based on some of the data that we've talked about, that how you order that information could have a difference, and particularly on a large scale, in terms of how many people choose to make that decision. What's interesting, and what I think we have to have honest discussions about, is I think this is one that's probably structured towards an outcome that most of us would agree is in most patients' best medical interests. And so it may make sense to make a choice of a frame that may not necessarily be explicitly neutral, but is one that we think is probably the most reasonable sort of frame to default people to. Another area that's implicit and in some ways explicit in a lot of what I've said is really understanding our patients, right? So that's critical for these issues about kind of what look like unrealistic optimism. So in many cases, as illustrated by the patient, I think, in our unit, they're really sort of speaking a different language, and it's important sometimes for us to use different language to be able to talk about things so that we can actually make sure that we're on the same page. We do have to ask the right questions. Asking about their belief of an outcome is not the same thing as asking about their assessment of a probability of an outcome. And really we have to, it's on us to figure out what's driving patients' decisions, especially when they don't seem to kind of line up. And in many cases, I think we have, there are tendencies largely driven by, I would say, some overzealous autonomy advocates among ethicists that we don't necessarily make clear recommendations, and that doesn't do our patients favor in cases where those are appropriate. So the problem, though, is still there, right? So framing effects and other biases are really pervasive. And as much as we would like to have neutral ways of presenting information, that often doesn't exist. And I wrote here, there's always something closest to the cash register, right? So this is sort of one of the favorite kind of examples in behavioral economics, is whatever's closest to the cash register in the cafeteria or the grocery store is what's most likely to sell, right? If you look at what's there, it's often the products with the highest marginal profit for the people running the cash register of the grocery store. Those often are not ones that are the healthiest products, right? That's why the junk is always there. They're the ones most likely to be sort of the function of kind of an impulse buy. Well, there has to be something there, right? You have to choose kind of what that piece of information is that is going to be in the kind of most salient position for your patient. And we can't just say we're always giving balanced information. I think it's important to recognize that we're often not. And that's not a problem as much as something that we have to own and make a decision about what we think we want to put closest to the cash register. So The upshot of that is obviously often kind of simply clarifying patients' values, which is the sort of common description of the way we should interact with patients. Simply clarifying their values often isn't going to clarify the decision, right? They might have all of these values. They care about quality of life, they don't want unnecessary treatment, and they don't want to die sooner than they have to, right? So that doesn't obviously translate into a decision in many cases. And it isn't that patients don't know what they care about. So I think we have to think about ways in which we want to be kind of active guiders of decisions. One, probably the most, again, in sort of ascending order of controversialness, the first one is just challenging statements or choices that patients make that don't seem to line up. I think there's a notion, and people are often communicated this idea that you shouldn't sort of challenge choices that patients make, but I would argue that that's probably not respecting their autonomy in many cases because you haven't kind of engaged them in a robust discussion about the implications of what they're choosing. I'm reminded of a clinic patient I had at Grady who, you know, I thought I had a very good relationship with, and time after time she would tell me, God's going to tell me when it's time to have a defibrillator. Right? She was a very functional woman with an EF of 30%, who was sort of, in many ways, who defibrillators were made for, right? And we kind of had to have this discussion every time. I said, I understand, I'm not, you know, this is your choice, but you need to tell me again sort of what the indication for this therapy is and what it's trying to do, so that I understand that you know, exactly how this messaging system is working right now. And at some point I even said, you know, because we had a very nice relationship, I said, what do you think my role is in God's communicating with you about the defibrillator? Where, you know, I think it's one of these cases where I think sort of challenging her and at least sort of pushing her to clarify kind of what decision she really was making was an important part for me of feeling like I was actually respecting her ability to make an autonomous decision. So I think where we get into tougher questions is really about how we try to correct for some of these biases, right? So there's a notion of sort of strategy that's been termed beneficent persuasion, which is in some ways makes a lot of sense. And I think all of us have probably engaged in this in some kind, where we sort of use the same biases and heuristics in ways that we think are more likely to promote good medical decisions. So a shift from absolute to relative risk. Relative risk overestimate benefit. People overinterpret relative risk in terms of estimation of benefit. Now, if you have something that you think is a really good idea for patients to do, saying that they have a 50% reduction in their chance of a heart attack, as opposed to saying, you know, 2 out of 100 rather than 4 out of 100 are going to benefit, may have a very potent effect on the kind of decision that people make. Use of vivid information, particularly to change this issue of particularly the availability heuristic, where people have, you know, a case in mind, using a vivid picture that sort of can counter that by giving them, you know, an image that is sort of equally potent in the opposite direction, can be helpful. They talk about that with regard to, you know, COPD patients and, you know, giving examples of, you know, consequences of smoking. And then, as we talked about a little bit earlier, the order of information presentation is something that I think we have to think carefully about and construct in ways that we think are most consistent. This idea of sort of how we structure defaults, both in our interaction with patients as well as at a policy level, is something that's gained some traction that obviously generates quite a bit of concern. And these are all strategies that have been used in other contexts, certainly in marketing and other kinds of places. There's ways in which that makes us feel uncomfortable, but it also does acknowledge some of the realities of the way people do make decisions. So I should give credit to whoever suggested this curling analogy, and I had a conversation recently, and I can't remember exactly who it is, so I apologize if you're listening. It is a brilliant suggestion that curling is one way to think of kind of how we help to actively guide decisions and kind of keep them on track. Of course, the worry is we don't necessarily want to turn patients into puppets, right? This is all an attempt to think about how we kind of work with our patients to arrive at things that are consistent with their values. So I think just to kind of close, these strategies of more active guidance are certainly least controversial in circumstances where people's best medical interests are clearest, right? When we think that people are likely to be affected by trivial things in context of relatively clear medical decisions, that's where they're most reasonable, I think, to think about. And then in situations where there's good reason to believe that arbitrary influences are actually appreciable. One of the sort of interesting aspects within the nudges, the sort of nudge literature, is they don't work in cases where people, or you could say they work properly in cases where people really do have very strong kind of pre-formed values. So there's a lot of kind of emerging evidence that these are unlikely to kind of override very strong preferences that people hold. And that's, I think, somewhat reassuring, but it doesn't alleviate some of the uncertainty that we have about these. So just in summary, we have lots of challenges translating information and values effectively into decisions. These challenges do threaten the process of shared decision making. There's often cases where we have to be more active participants in guiding decisions than have commonly been recognized. And that active guidance may not undermine autonomy and substantially advance shared decision making. But obviously the line between active guidance and problematic manipulation can be blurry. And most important is that we're transparent with our patients, with ourselves, and that we're clear about what it is that we think we're doing. So I guess I'm supposed to give questions. So we'll go through 3 questions quickly. So our tendency to make probabilistic judgments based on the most distinctive cases is an example of what heuristic? Representativeness, availability, anchoring and adjustment. Right, so that's an example of the availability heuristic, this sort of thing sticks in your mind. That's a very vivid example. True or false? In considering situations of potential gain, we are more willing to take risks than when considering potential loss. True? False? False. We're more likely to be risk averse in considering gain and risk taking when considering loss. And finally, the effect of defaults goes away when people are warned that they are about to be defaulted. That's false. All right. So I just would thank the Greenwald Faculty Scholars Program for supporting a lot of the work that I do, and some colleagues, Modi Gord, Scott Halpern, and Steve Jaffe at Penn, who I've worked with on some projects looking at sort of appropriate use of defaults. So, thanks.
So as always, very thoughtful and provocative. So it's interesting. We were sort of talking about this a couple of months ago in my heart failure clinic about, and I said something which you would probably. I'm biased by my biases, I guess, because I said I felt like shared decision making was often a myth, and that the percentage of times it was real, it was 5 or 10% of the time I see patients, and the rest of the time, at the end they just say whatever, and now I'm going back thinking, well, how many biases have I inserted, and should I be inserting those biases, and in a certain sense you feel like you should. So I guess one of the question that goes with that is not how screwed up is Bob and how he deals with his patients, but is what's sort of the take home for how we should think better about when we enter in these decisions, and in a certain sense it's clearer on those big decisions about end of life or defibrillation. It's harder actually on those more subtle decisions about lifelong statin therapy or lifelong anticoagulation therapy, which has sort of a longer cumulative toll, I think.
So I agree with, I don't know that I would say it's, I wouldn't say it's a myth, and I think it's largely misrepresented and we have the wrong expectations for it, right? So, I mean, a shared decision-making process for something like that isn't the same as a family meeting to discuss, withdrawal of care. It's it happens along a big spectrum, and I think the right paradigm is making sure that the right kind of values and preferences get put in there. And in many cases, there aren't values and preferences that are going against medical recommendations. And so I think in many ways we've kind of misconstrued maybe what it looks like. I think the kind of take home is that when you look at the effect of our conversations and our presentation of data on decisions that people do make, I just think it imparts a really strong responsibility on us to do that well, right? So to do that in ways that we think are most likely to yield results that are consistent with what people want, and to be very cognizant of when people sort of are have kinds of interests or preferences that are likely to kind of get them off that track. So I don't necessarily think that it's a problem that we don't, every decision doesn't need to be deliberated on. I think that's not what an appropriate shared decision-making strategy really is. I think it's about, so one, when patients sort of raise questions, figuring out how do we then engage in that discussion, and two, kind of figuring out how we structure things routinely such that we think we're, because we can't truly do it neutrally, such that we think we're doing it in the best way that we possibly can. And I think I would say that's one of the problems with some construction of decision aids, is that these have been constructed without carefully thinking about kind of what they're defaulting people to. Yeah.
Superb talk, and I think it's probably an appropriate follow-up to my talk last week about frailty, and this is when a lot of those decisions are made, and I think what we're doing is now we tend to avoid them, or we wait too late, and that is that the prognosis with frailty is so bad that I think when you begin to identify that onset, that's clearly enough time that we need to sit down with the family and the patient and all, and if you miss that opportunity, the patient will no longer be a part of it, but excellent discussion.
No. Thank you, and I think it's related to, I thought about the same thing, that it seemed appropriate timing in many ways, because it's a good example too of where one of the most important pieces of all of this is understanding the patient, and that's hard to do in a lot of ways when care gets fragmented, and we're in times where that's not always easy.
Let me ask you one more. So I'll take this into the sort of research world. You talked about the phase 1 trials,
Yeah.
and we've all been in that situation where the patient, you consent them and you say this trial has no benefit to you. This is to help future generations. It's helped to move things forward, and they sure, sign on. And you know that they're thinking it's going to help them. But also, I think the investigators sometimes, and I would point to the stem cell trials, right? I mean, there are two major, 3 years ago, stem cell trials came out that were phase 1 trials, not with an endpoint of survival, and both investigators get on public, both Edward Marban and the guys from Louisville get on TV and get on radio and say, look, stem cell therapy works. And, so I think we see that same optimism in those phase 1 trials in the investigators, which is, in my opinion, misplaced.
Absolutely. So the first paper I ever wrote was one about paying people for participating in research. And I remember there was this letter to the editor from an oncologist. And this is a big, sort of early phase research, and is really interesting there. And we made this claim that it was not problematic to pay patients. It wasn't any different, really, to pay patients in most cases than it was to pay healthy subjects. And it was very angry kind of, letter. That's terrible, that's terrible. I still maintain that if you paid phase 1 oncology patients, your recruitment rate would go down and not up. In large part because I think this would become abundantly clear that nobody's paying me to do something that's not in my, that's not immediately in my best interest. So this sort of concept of what's been called the therapeutic misconception or therapeutic misestimation is important. I think and I didn't mean to dismiss its existence. It's operative for investigators, it's operative for patients. What I do think is important is some of these data that show when patients give you answers about their own likelihood of benefit, it doesn't necessarily mean that they don't understand the chances of a patient in that trial getting benefit. Sometimes it's a deeper issue about what they're trying to say to you by making that statement than it is just that they don't understand you.
Yeah, the other part of that is that I was listening on the radio the other day. Somebody had written a book called The Cure, and had gotten into issues in placebo that there are actually
Oh, yeah.
physiologic effects of a placebo, changes in the brain that lead to better outcomes, and how does that fit into our discussions with patients, allowing some hope in the setting of statistics and realism? That's another layer of this.
Absolutely. So placebo effects are 100% real and very powerful and really hard to figure out where they fit clinically, right? So, particularly because we have very few therapies that that we can just give people and just rely on placebo effects and never worry about harm. It becomes it's a really interesting issue, and I agree 100%. The biggest challenge with placebo is the notion that they rely on deception. And that's really tough. There's also nocebo effects, which is the idea of sort of taking something away, being harmful, is sort of the same issue. So this is it's a great point.
Okay, well, with that we'll close, but thanks a lot, Neal. That was fantastic.
The preceding program is copyrighted by Emory University.